So I want to I want to make sure we have enough time for Roula. That's like, I have so many questions. And first of all, thank you. That's incredibly impressive. You know, what I love is as technology improves, that changes the landscape for the possibility for your devices too, to miniaturize them and to do remote work. And it's just amazing and fascinating. So what I'll do is I'll have Roula present, but then if you guys have questions that are burning, feel free to ask Ami in chat. And then if we have some time at the end, we can go ahead and have questions live. Again, I have a bunch of questions myself, but we can also follow up via the listserv afterwards to continue the conversation. But I want to make sure that we have enough time for Roula to present her work as well. And Roula, I'll have you go ahead and introduce yourself as well and where you're at and kind of what you're going to be presenting on. But again, Ami, thanks, but stick around if you can, because there's going to be lots of questions rolling in, I imagine. Okay.
Thank you for having me present on my talk, and thank you for having me talk after Ami Klin. So this is a tough act to follow at all levels, and he is one of my heroes too, and I've been to his talks. So I'm here to talk a little bit about the about the rapid interactive screening test for autism in toddlers, and the development of it, some clinical models, how we've been using it to also improve access, and more so in those who are culturally diverse and from underserved communities. I am originally from Beirut, Lebanon, and I am trained as a child neurologist at the American University of Beirut, and moved to the US, to Boston 21 years ago, and completed a fellowship in neurodevelopmental disabilities at Children, and then was in the Boston area at Tufts and then UMass for 8 years, where I developed the RITA-T. I have no conflict of interest, and I do not receive royalties from the RITA-T. We actually created a fund in the department where all the training, we build more of a research fund so that it can also help and support other research projects. So there is a shortage of diagnosticians, and ASD signs can be seen less than 12 months clinically, but diagnosis is still delayed. And minorities and underserved population experience further delays. Early intensive intervention is crucial, and we are all trying to find a way to get all those who need it really fast. Now, there needs to be a system to screen more efficiently those with high risk of ASD. So again, the American Academy of Pediatrics recommends screening, but at the same time, we now know more and more that those who are refugees and immigrants may not have a consistent primary care provider. So there is more attention also on early childhood providers, early intervention, Head Start, and WIC to really help them be part of the system. So basically, if we do screen as well child visits, we're going to be able to pick up children who are at risk. But also, if we start working with early intervention programs and children already identified at risk, and administer a level 2 screening test, then we may be able to identify those who are higher at risk for ASD. The whole idea is that we can differentiate and triage then children so that they don't delay each other on our wait times. And again, we all use, most of us, the MChat, and when it's administered appropriately, it has a very good positive predictive value, but at a lot of the times, if it's not administered correctly or not scored correctly, it may cause a higher increase of referrals. And so the idea came of how do we help triage those kids so that we can improve our wait time, and then who would be our best partners in the community. And so we started by developing the test and validated it for 18 to 36 months. And it did evolve from different kits that are not as sophisticated at any material, but we added also more material that is more representative of the diverse children we work with. So we developed an administration protocol and a scoring protocol as well that we validated, and we are evaluating the early signs of autism, which are the answer to name, following a point, joint attention, eye contact, shared enjoyment. And we are also assessing how the toddler reacts to their caregiver when they pretend to cry or when they have a neutral emotion. And as in every test, there are some cognitive components also embedded. For the training, so there are 9 activities, and the lower the score, the more typical the response, the higher the score, the more atypical the response. And we were able to also map out the risk cutoff scores, and that have been consistent across several settings. So the evolution of the test led to creating, initially the trainings were all in person, and then as we were getting more requests for training, then we developed the training online. We just moved it to the Children's Hospital educational courses last July. And so it does include 9 interactive presses. It does not rely on language. One can reliably train in 3 hours. There are excellent correlation with diagnostic tests. At the time when we were validating it initially, it was the DSM-4 and the ADOS-G. And since then, we've correlated it as well with the ADOS-2 toddler module and module 1 and the DSM-5. And we also collect developmental information using the Mullen. We have translated the manual scoring sheet to several languages, and the cutoff score that we have been finding to be really consistent across different models and settings. If a child scores less than 12, they are low risk for ASD, and I will show you the data and our ROC curve as well. And if they are between 12 to 16, it is a medium risk, so they can still have ASD diagnoses, but there are also children within that cutoff score that have developmental delay. The score more than 16 is very likely associated with ASD, and you will see, I will show you the numbers. The administration and scoring can all be completed within 20 minutes. And as someone gets more familiar with it, it actually can be closer to 10, 15 minutes. I will not show you the video now because we had the release only for educational purposes and not to be posted. And so the generalization and clinical models, so this is our initial paper that showed that it differentiated well between those with developmental delay non-ASD versus those with ASD. At a cutoff score of more than 14, we had excellent sensitivity and specificity. So that was the initial pilot with a small sample. The second 2 larger studies that came were from our collaborators in Calgary, Canada, from the Developmental Behavioral Pediatrics division there, where their goal was to really reduce the wait time for toddlers 18 to 36 months. They had a wait of a year. So they developed a model with RITA-T that included screening, MCHAT, and RITA-T, and then they would distribute the children into low risk, moderate risk, and the high risk groups. Their current process from time of referral to whether the child is in which category of groups and then they receive the treatment is actually 7 weeks. And they continue to integrate the RITA-T in their medical record. So there is a paper that is out there from that group on the model. And then, so basically, they used to have the full evaluation for everyone that is referred. And through this model, they only used the full evaluation for those who are medium risk. The low risk, they did more testing and they were able to staff with different disciplines. And the high risk, they did provide them the diagnoses without doing the ADOS. So then they were able to see more children and in a shorter amount of time. They also looked at the psychometrics. So they had 239 toddlers and they found a cutoff score of more than 14. They also did the ROC and it was 0.953 for sensitivity and specificity. And they identified that it was a very good addition in their tools. So then we wanted to see how it would be if we connected, if we collaborated with early intervention programs. So we have a pilot study that was published last year, and we have 2 manuscripts that are being prepared. So the initial pilot was completed in the Worcester area in Massachusetts. So this is 1 hour west of Massachusetts, west of Boston. And it's a very diverse and underserved population. And so we collaborated with a major early intervention program there. And we trained 4 of their providers on the RITA-T. We created a system. Initially, it was a study system where they would identify a child within the program. That child would be referred to those who trained on the RITA-T. They can start the conversation with the family. Then they were referred to a study psychologist group, a team, where they were evaluated, and then they were provided with a diagnosis. So when it was initially as a pilot, we were able to get them in within 6 to 7 weeks. During that time, the referral to ABA started decreasing in that area from 30 months of age to 28 months of age. What we also found is that it really improved the communication between primary care, early intervention diagnosticians, and families. And we looked also at the inter-rater reliability of the RITA-T, and it was very agreeable. So then, if we remember the cutoff scores, so it also was consistent in this little pilot that was controlled with early intervention. I think one of the important lessons that also was clear from this program was really collaborating with early intervention providers who can be there for the families, especially those who don't speak English or who are new to our system. We've also collected several qualitative surveys where it was felt to be favorable, whether through the early intervention or parents. So then from that pilot, we went on and trained more early intervention programs and also primary care programs in the central Massachusetts area. And we trained in the central Massachusetts area, we trained 10 programs, and then we reliably trained 3 to 4 in each program and developed a system, and then how they would refer to primary care. And same in primary care clinics, we trained pediatricians, nurse practitioner, pediatric residents, and we created within the practice as well a system of how to integrate a screening model within their practice. And one of our practice that we collaborated with, we developed it as a QI project. We're actually currently writing, she's writing this project, and she was able to also receive mock certification for that. So the diagnostic RITA-T clinics, and we did the same model by telehealth, where the regular evaluation, but they were much shorter, so 90 minutes. Early intervention came usually with the family. They were very focused. We've also developed a checklist history structure, the EASY early autism screening inventory checklist that helped us also structure the visit and provide some presses as well. So then we looked at the results in the real RITA-T clinic. So after we received those referrals from the community, whether from early intervention or from pediatricians, and we found that we received referrals from 169 early intervention provider and 145 primary care. And this was a review over 3 years. The RITA-T scores continued to be different between both groups, but I want to mention a couple of more important findings. So the wait time did improve for those who came through the RITA-T clinic, and the cutoff score continued to be very consistent. So we had a cohort of 356 toddlers, so they were referred from the community by different providers who were trained on the RITA-T, and the cutoff scores continue to be consistent, with 12 to 16 being the moderate risk and really 17 being an excellent cutoff score with 99% PPV. So this is the ROC curve and the area under the curve that was pretty decent, 0.89 as well. And a scatter plot that identified 1 false positive and 3 false negative, with 6 that scored just under the cutoff score. And I'm happy to go over these if we have time. So one of the other models that we have been also doing is really working with primary care to use the RITA-T as a triage so that they can then provide a diagnosis for those who have a score more than 16 because of the high association with ASD. We are about to complete one pilot training in that sense, where we were able to develop the visits, the billing, the reports. We trained primary care on the CARS, administration of the CARS, on the DSM-5 checklist interview. We are at month 10 of 12, and they were able to diagnose 20 toddlers with ASDs. And we met monthly, we reviewed the cases, we discussed the cases. So those are children that access services. And we just started another pilot group with other community health centers. So we have trained almost 3,000 under RITA-T, and we have trained several early childhood providers in different states, clinical, academic, community settings. We are starting to compile also data from the different groups, and within each group there are trainers, and they have also set up their clinic in a different particular way. We continue to do quarterly workshops lives. We have a course online, and we are building a train the trainer curriculum as well, so that we don't have to review the videos and ascertain reliability of those who then become trainers. And the PCP trainings and further EI program trainings and early childhood, we have developed them as QI projects, and we're generalizing them in Massachusetts and in other states as well. The research project, we have developed RITA-T telehealth through COVID time, and we found that it actually correlates nicely with the RITA-T in person. We are also working with other groups in different countries. So we have a very active group from child psychiatry in Istanbul, where they translated the RITA-T in Turkish, and we did trainings and reviewed their videos. They were able to assess 81 toddlers, and their data is already analyzed. We're submitting the manuscript, and they have a very similar cutoff scores and drop curves. There is another group in Shenzhen and Shanghai, and a group in Montreal that translated it into French. We are starting with a pilot training with a group in India as well. And we started as well training a group of educators in Brazil. So we're looking at validating it further in those who are 12 to 18 months. We are collaborating with a couple of groups that are studying, gathering data of the RITA-T in NICU follow-up clinics and Down syndrome early developmental clinics. And also looking at its validation in children who are 3 to 4 years who are nonverbal. So this is, we've translated it in Portuguese, Spanish, French, Arabic, Chinese. So the ongoing project are Montreal, Turkey, and China. And there was a small pilot that also came out from Beirut before August 2020. So it found good correlation, and that it was a very helpful tool. But since then, there are definitely more economical or difficulties to pursue more studies now. So the telehealth RITA-T is available when someone signs up for the in-person RITA-T. We also have been developing a training for early childhood providers so that they can follow with families after a diagnosis of ASD, especially those that are from different cultures. We have Brazilian, Haitian Creole, and Spanish and Arabic. So each time I present, the slide keeps increasing with names. We have wonderful partners and people, and really nothing could be done if we were not collaborating, all of us across the globe, and most of all the families. And they always accept to be part of the studies, to be videotaped so that they help other families. So this is our, we have a website that we also try to update regularly, and there are information on the course, and you can reach back to us at any point in time if you have any other questions. Thank you. So.
Wow, great job. Amazing.
Thank you.
Yeah, I was just, as she's closing out, I was just thinking, that's super impressive. I wasn't as familiar with the RITA, and now like, I kind of am. So I mean, I want to like use it more. It just got me thinking a couple things before and open up for questions from everybody. But over the past this month and last month, we had like several different presentations, but they're really different kinds of tools, right? And I think that's why I'm appreciating what's happening in our field. One is this, people are actually doing really good work, doing the right research to validate these different tools. But there's some tools that are like, don't require a whole lot, like whether it be, meaning like a whole lot on our side of it, whether it be Cognoa or whether it be Ami's work, or it's like, now we have a screening tool that you can put in front and give us data, and which is amazing. And we never had that before, right? Then you also have these other tools, and we didn't have like the ASD PEDS, the telehealth, Zach Warren stuff. We didn't have him present his stuff again. And you have the STAT as well. So you have these other tools and the RITA and even like the NOTA to some degree that require more participation, expertise on our end, but that give us another level of what can we do to evaluate these kids either remotely or in person, because we really need to do something. I mean, all of us have huge wait lists, so we need to approach it in the right way. And what I'm appreciating in our field is these different tools that are coming about with the right evidence behind them, and to really think through. I think for me, the big question is honestly, as a pragmatist, is workflow. Like, what does this mean in terms of the workflow? So like if we put these devices out in pediatricians' offices or send them out home remotely, screening devices or otherwise, how does that affect our workflow in a way that, and there was a discussion real quick in chat about like, what do we do with indeterminates? What do we do with false positives versus false negatives? We want to make sure we capture accurately all the kids through screening and through what we do. So it's just, I think there's a lot more thought that needs to be done as these devices and tools come to bear. Like, how are we going to use them in the real world? And the people like you guys who are presenting today are very aware of that and doing all the right thinking around those issues. And one last thing before we also put out there for questions, we have about 5 minutes left, is not that it's an elephant in the room, but there was an interesting paper that came out, was it last week or earlier this week, on the JAMA one, that basically by developmental pediatricians, I think several people on this might have been involved in the study, that basically concluded that we don't need to do ADOSs on kids. So I thought that was an interesting paper, and I encourage all of you to read it. I thought it would be an interesting presentation to do on this group too, and how we react to it. And honestly, my reaction is surprising myself. I am not in any way against what they said on that paper. I think it's worthy of its own discussion about why they put that paper out, methodology, both concerns and strengths, and what that might mean for our field. But just so you know, if you haven't seen that paper, it's worth reading. A lot of people who aren't actual psychologists doing diagnostic work like we do have talked about that paper, and it might make an interesting splash in the field. So just want to throw that out there too as another possible interesting, really topic, especially that hits us. But feel free, we have 5 minutes. If we have time for at least 2 questions. If anyone wants to either unmute, raise their hand, or ask Ami or Roula any question you might have, feel free. Don't be shy, they don't bite. All right, I'll ask one. So, you kind of hinted at this. I don't know if you can talk about this yet, but whether it be on the Cognoa presentation, the indeterminate, I think one of us diagnostically, our big question is, what is it? What are these kids that we're missing? Whether it be a false positive or false negative. This is true of the ADOS. This is true of the RITA. This is true of any of these screening devices. Like, what I'm really curious about is not the 80% or 90% that we get right, but the ones that it's missing. Like, is there anything you can tell us at all about the ones that it's missing at all?
I can certainly do that. We have followed up the children from the first trial that I told you about, the replication sample. And here's the issue. The issue is comes down to how do we feel about the diagnosis of 16 to 30-month-olders. And what tends to happen is that, and there's going to be a publication about that, what happens is that those children who fall in the borderlands between ASD and non-ASD, meaning those children who have very specific profiles on the ADOS and on the Mullen, they end up having categories such as subthreshold autism or something that basically the clinician is not ready to make a definite diagnosis of autism at that point in time. And when you follow those false positives, there are two things that I can say about them. Number one is that half of them became positive over a year later. And this is basically the problem that we have with the wait and see approach. We don't feel very comfortable, then we see the children back again, and off they are there. The problem that I have with this approach is that if we don't give a diagnosis of autism, the children often will not have access to early intervention, at least the adequate and intensive one that comes with the diagnosis. So this is one of the things I can say. The other false positives, another 30% are kids with other developmental conditions. So that's what I can say about the false positives of the initial trial. I think that if I may say this is just my deep belief these days. The problem with our field, even though we always think about false positives because you don't want to alarm people, you don't want to misplace resources, all these kinds of things. The problem with our field, as Whitney is in this call, Whitney Guthrie, the problem of our field is false negatives. If you think about the number of children with autism who receive special education services, over 700,000 kids, okay, who receive Part B services, special education services, less than really 1 in 5 actually is identified before the age of 3. That's in the report to Congress by the Department of Education. So what I'm really concerned about is that we wait and wait and wait and wait. By the time we actually identify the children, they have developed not only autism, they develop the burdens of autism, including intellectual disabilities, language disabilities, and severe behavior challenges. So I have a particular strong view of false negatives and false positives in our field.
No, and I appreciate that. And we can wrap up with this thought. I mean, to me, just to get on my pedestal for a second too, to me, it's not about accurately identifying the kids with autism. By that, I mean, it is, because that's what I do. But it's like, why wait? I mean, what I hate about our system, and this is a systemic problem, is we shouldn't have to wait for the diagnosis to get these kids the help they need. So, and that's what's like, oh, give them the diagnosis early. Like, no, get them the help early, whether that means speech language, OT, ABA, like symptom-based stuff. Like, yeah, eventually get them the right diagnosis, but let's get them the help they need right away. So
that's what diagnosis is for. I totally agree with that. We tend to forget that the only reason why we spend so much time assessing children is not for assessment's sake, is to provide them with access, eligibility for, and access to the treatment they need.
And as someone pointed out in the chat, the pesky thing is about insurance and time spent, and that's how the adoption of these tools is also going to go. So again, we could go on for 4 hours on these discussions. I love them. Please continue them on the listserv if you'd like. Again, Ami, Roula, thank you so much for being generous with your time and your data and your ideas, and let's continue the conversation. And I think next month, again, it's going to be about adult assessment in autism, but we can always come back to this topic too. There's just so much here to talk about and figure out as a field. So thank you, everybody. And thank you for taking the time for this hour. See you guys next month.
Thank you.
Thank you very much.